Thank you very much. Good morning to everyone. And it is February, it's American Heart Month. So we're all keyed in to become aware of our risk factors and, more importantly, take action on those risk factors. So, as she said, I did family practice for over 30 years, but I really found a passion in dealing with lipids and heart disease and whatnot. So very few people have really ever heard of a lipidologist. But the specialty came around in 2005, and ever since, we have a slow trickle of lipidologists that become board certified. But we're dedicated to the study of atherosclerosis and the prevention and treatment of the diseases that are associated with that. So in the clinic, we do a very detailed cardiometabolic evaluation of people with a history and a physical. We use advanced testing beyond the regular standard lipid panel, which sometimes gives us some false cues. But we know now that we're able to prevent, reverse, or even arrest the process of atherosclerosis if we identify all the risk factors and get to work on dealing with all of them. So we're trained to work on lifestyles. As far as medicines, we know the risk and benefits of medicines. And we like to form a partnership with our patients and use shared decision making in coming up with treatment. So, why lipidology? I kind of covered some of that. But basically, we have advanced knowledge, special training, and the diagnosis and treatment of those diseases that involve cholesterol and triglyceride. Heart disease is the #1 killer of men and women in the United States. So we ought to have a specialist who focuses on prevention of that. 1 in 3 deaths due to heart disease, and a heart attack occurs every 43 seconds in someone. So the process of atherosclerosis, which is the collection of cholesterol within the wall of the artery, is progressive. It takes time to do, and it's very complex. So we have time to evaluate people, identify those who are at risk, and we have many targets that we can work on, both through lifestyles and medications. So we evaluate risk factors, and we use advanced lipid testing, and we truly focus on prevention. If you've not had an event, stent, bypass, heart attack, stroke, but you have risk factors, we want to keep you event-free. If you've already had an event, we do our best to make sure that you don't have another one. So, ladies, you're at high risk for heart disease, just like men. Now, nearly 80% of these events can be prevented. That's pretty amazing, 80% prevented. But cardiovascular disease continues to be your greatest health threat. 1 in 3 women are going to die from cardiovascular disease. It's a lot, it's too much. But together, we can make a difference. We're talking about atherosclerosis. We're basically looking at 3 areas of the body that this process involves. It's the blood vessels in the heart, which can lead to angina, stents, bypasses, and even heart attacks. We're looking at the brain, narrowing of the blood vessels within the brain that can lead to strokes, and narrowing of the blood vessels in the carotid arteries from the heart that can cause strokes. And then in the legs, we're looking at peripheral artery disease. So this causes people to potentially, lose limbs and whatnot, amputations and whatnot. And it's more common in diabetics and in those who smoke. So our standard lipid panel basically has 4 things on it. I've added the non-HDL cholesterol because it should be looked at. But we start with triglycerides. Those are a type of fat that come from animal fat and vegetable oil. They're very important. We don't give enough respect to triglycerides. Total cholesterol is going to be the cholesterol carried in the LDL particles, the HDL particles, and the triglyceride particles, because they have some cholesterol as well. So non-HDL cholesterol, probably a new term to most of you. If you take the total cholesterol and subtract the HDL from it, that basically is non-HDL cholesterol. So it's all of the bad cholesterol, not just the LDL. And it's important in patients who have high triglycerides or low HDL or the combination thereof. So our insulin-resistant patients, metabolic syndrome patients, diabetics, frequently the target for treatment should probably be non-HDL more than just LDL. The goal for that non-HDL is going to be 30 points above whatever your LDL goal is set at. Now, it's important to know that cholesterol and triglyceride cannot just get into the bloodstream and move around and go where they go. They have to be carried by particles that allow them to be carried, because these particles, which you see, they're formed primarily in the liver, okay? The VLDL come out, they're mostly triglyceride, they have some cholesterol in them. The VLDL remnants or potentially can get in the wall of the artery. Then we move down to the intermediate density and the LDL particles, okay? So if we look at this box here, I'm not very good at outlining it, but that aqua box, that is all what we consider non-HDL cholesterol. So it's more than just LDL. You look at the corner down there, you're going to see HDL particles. The HDL particles are smaller than the LDL particles. They are responsible for trying to keep the walls of your arteries clean and prevent atherosclerosis. We're going to say something about these little purple LP little a in a minute here. Triglycerides come into the body through animal fat and vegetable oil. They're stored in our fat cells. They're released throughout the day and night to serve as fuel for muscles. So what keeps your heart beating through the night when you're not eating? It's parts of the triglycerides, okay? So high levels, which are over 200, actually increase the risk of coronary artery disease, especially in women if you also have low HDL cholesterol. So there's a thing called hidden risk, especially in insulin-resistant patients, pre-diabetic, diabetic, and that is due to elevation of those triglyceride-rich VLDL particles and remnants, because they potentially can get in the wall of the artery. They carry 5 to 20 times more cholesterol than the LDL particles do. There are not as many of them, but they certainly can make their contribution. So triglycerides are important because of that. So non-HDL cholesterol in people with high triglycerides is probably a better measure of risk than not. Again, total cholesterol minus the HDL is non-HDL, and it's all the bad cholesterol. We fight it with improvements in lifestyle, reducing sugar, reducing weight, reducing alcohol, and that can help control those triglycerides. This is a landmark study, the Framingham heart study that was done years ago, and it looks at the risk of coronary heart disease by level of triglyceride, and it's divided into men and women. So if you look at the vertical risk scale, that's coronary heart disease. The horizontal risk scale is the actual triglyceride level. One thing to note here is that when men, in the blue, get above 150, their risk of heart disease goes up. But look what happens to the pinkish orange columns for women. When you hit 100 on triglyceride, your risk is already up. So triglycerides are more risky in women than they actually are in men. HDL cholesterol, we call it the good cholesterol because it's intended to protect the walls of the arteries, clean out the arteries when there's cholesterol in there, reduce inflammation, et cetera, et cetera. So in general, a higher level of HDL cholesterol is protective, but it's not always. It's not always. Normal HDL cholesterol levels are at least 40 or higher in men, 50 or higher in women. But this is the key. The beneficial effects of HDL do not come from the cholesterol that are being carried in the particles. It comes from the almost 100 different proteins that are on the outside of that particle that allow the particle to take cholesterol from the wall of the artery, reduce the size of blood clots, reduce blood pressure, reduce inflammation, etc. Now, in insulin-resistant situations, pre-diabetics, diabetics, metabolic syndrome, and inflammatory conditions as well, these affect the proteins on these HDL particles, and so you may have a good cholesterol that's actually bad. In fact, in some people, the HDL cholesterol actually causes atherosclerosis. It works in completely the opposite direction. So advanced lipid testing, which we do, can identify those patients who have the not so good HDL cholesterol. We're familiar with LDL cholesterol. It's called the bad one because it gets in the wall of the arteries, stops it up, leads to heart attacks, to strokes. The interesting thing is this, though. Now, bad cholesterol is the target of almost all the guidelines, right? 50% of patients hospitalized with coronary artery disease already have an LDL cholesterol level that's at or below the target level. Now that should tell you something. What's wrong here? Are we not setting the goal low enough? What is going on here? Well, it's that hidden risk that we talked about in the triglyceride-rich particles, the VLDLs, that are carrying 5 to 20 times more cholesterol than the LDL particles. You're not going to see that on a standard lipid panel, but if you have the non-HDL cholesterol, that gives you an idea of what the risk is. Okay. So the risk for future cardiovascular events is better reflected by measuring the actual number of particles that are carrying the cholesterol. And that can actually be done in almost any physician or clinician's office. It just has to be offered. The problem is it's not truly an established part of guidelines, so most clinicians are not familiar with it, and therefore they don't use it. We have this term called discordance, which is when the level of LDL cholesterol on the lipid panel does not match up with the number of particles it takes to carry that LDL cholesterol. We call that discordance. Very common in insulin-resistant patients, type 2 diabetes patients, metabolic syndrome patients. Whenever that's the case, you always go with the LDL particle number, or is as listed there, ApoB, which is that single protein on the outside of the bad particles. You can measure either one. Gives you a truer risk of what the cholesterol actually is. Because it's the particles, the LDL particles, that build plaque up in the arteries. That is truly the key. But we identify that with our advanced lipid testing. So this is a picture of an LDL bad cholesterol particle. It's cut away so you can see the inside core, but the red structure on the outside is the ApoB protein, which identifies actually all of the non-HDL cholesterol carrying particles. But primarily in the numbers that we see, it's going to be the LDL particle. There's some other types of lipids and cholesterol on the outside, but if we look on the inside and we see the purple and green, those are triglycerides and cholesterol. That's the only way they can travel through the blood because they can't dissolve in the blood. But inside these LDL particles, they can be carried and transmitted, and that's how they get in the wall of the artery. So this is a slide regarding atherosclerosis, and what you see at the top is going to be the blue is where the blood flows. This is the lumen of the blood vessel. In other words, that wall would go all the way around, okay? Just looking at a portion of it. So we have LDL cholesterol. We have LDL cholesterol here in the particle, and it has to come in contact with the wall here, and if it sticks to the wall, it's going to move through, it's going to get inside, and that signals the wall to say, we have a problem because we don't want cholesterol in here, we've got to do something about it. Well, the problem is the body doesn't really know how to handle it well. It sends in white blood cells, they change into macrophages, they start gobbling up this LDL cholesterol. They gobble, they keep, excuse me. There we go. They gobble it up, but they eventually die. And so they mass together, they form this big yellow plume there of necrotic tissue and cholesterol, and finally it grows to a point where it's actually going to rupture through the wall of the artery and mix with the blood. The blood is going to then try to seal that leak with a clot, and that's the cause of 85% of heart attacks. A rupture of the cholesterol into the blood flowing chamber, the clot grows too big and literally fills in and blocks the blood flow. That's 85% of heart attacks. And even scarier than that, 70% of heart attacks occur in areas of narrowing that's less than 50%. If you went and had a stress test, a regular stress test, would not even pick that up. Oh boy. I put my hand where it didn't belong. Okay. So that's the problem with most heart attacks, is that event right there. So when you look at cardiovascular risk factors, you have to go beyond the cholesterol. You have to look at metabolics. You have to look at inflammatory markers, and certainly genetics, most of which we get from family history. So our diagnostic test report is going to look at the lipids individually, as well as inflammation, metabolics, and genetics. All right, so let's talk about these LDL particles a little bit more. We said that it's the number of particles that determines whether it's going to get in the wall of the artery or not. So there are two scenarios here. Both these LDL particles are containing 100 milligram per deciliter of LDL. So that person's LDL, let's say on the left, would be 100, and they have large particles. But look over here on the right, still 100 on the LDL fraction on the lipid panel, but the particles are small. Well, to carry the same amount of cholesterol, it takes up to 70% more of the small particles than it does the large particles. So if you're somebody with small particles, you're at greater risk for heart disease, even though you have the same amount of LDL cholesterol, which would look low. Another scenario, normal cholesterol per particle on the left side, but on the right side, there's less cholesterol per particle because there's too much triglyceride mixed in with those LDL particles. So it takes up to 40% more in people who have high triglycerides. So that's part of that hidden risk we talked about, where up to 40% more particles, and again, it's the number of particles carrying the LDL cholesterol that is the risk. Okay, we said we were going to talk about that little pink particle called Lp(a). As you can see, it pretty much looks like a LDL particle. It's got the ApoB on it. But if you look along the top, it's got this squirrely little blue protein, okay? Lp(a) is an inherited particle. This is what the problem with it is. It delivers extra inflammatory lipids and cholesterol in the arterial wall when it enters. It interferes with the body's ability to manage clots. So in that previous slide where we showed cholesterol rupturing through the wall, getting in the blood, and the clot forming, wow, clots go crazy when Lp(a) is elevated. So it increases the risk of heart attacks and strokes, even in patients who have normal lipids. I see families of people, they all come in, they say, why are we having heart disease? We all have normal lipids. It's because they have Lp(a). That has to be dealt with. It's inherited. So when one family member has it, you have to check the other family members. It also increases the risk of aortic valve stenosis. So the aortic valve comes from the left side of the heart, lets the blood go through to the rest of the body. It cakes up with calcium when Lp(a) is elevated. Diet and exercise don't do a whole lot for it, but the treatment is to set the LDL cholesterol goal even lower if you know the person has Lp(a). So who would need Lp(a) testing? Personal or family history of premature atherosclerotic cardiovascular disease, strong family history of heart disease, multiple atherosclerotic cardiovascular events in patients with normal lipids, and elevated cholesterol that, let's say you take a statin and it's just not even moving. Why is that? Because statins don't lower Lp(a). And if a lot of your cholesterol is Lp(a), you won't see a change. Now we have genetic forms of high cholesterol. Boy, especially here in South Louisiana, we get that French-Canadian influence and gene. People who inherit a gene that causes two problems have very high cholesterol. Number one, they produce too much cholesterol. Number two, they can't clear the cholesterol well. So this is a genetic form, and typically you're going to be thinking about this if your LDL cholesterol is at least 190, but some people, it can be 500 or more, okay? So people are born with this high cholesterol, so heart attacks occur very early. It's very common here in South Louisiana. There are two forms of it, and I say the bad form and the really, really bad form. The really, really bad form has two genetic defects compared to one with the other, and it all depends on how high the cholesterol is. Now, many of these patients are walking around with levels like this, and they look like they couldn't be any healthier. That can be deceiving. We have to detect these people early and aggressive treatment, otherwise they're having heart attacks and strokes at an early age. So for patients who have this, we're checking their children at age 2. Between 2 and 9 years of age, they need to know their cholesterol because they could have been born with high cholesterol. Universal screening for children is between ages 9 and 11, whether you have family history or not. 9 to 11 is where initial lipids should be done. Now, people with high cholesterol levels like this, we need to look for deposits of cholesterol in strange places. You can see these eyelids here. See those yellowish deposits above and below? That's called xanthelasma. It's literally cholesterol. Okay, so we look for that. Another place we can find cholesterol is in the heel cords, in the Achilles tendons. You certainly can see that the one on the left is very abnormal. You can't even see a heel cord. It just matches up with the calf muscle. On the right, it's a little bit more identified, but it's thicker than it should be, and it rapidly turns wide. And the other thing we see is you run your finger up the Achilles tendon, you may find knots like marbles or whatnot. And that's another way that these xanthoma can present. So why do we do advanced tests? What are they useful for? Well, unfortunately, 50% of patients learn that they have heart disease at the time of sudden death, and that's not when you want to find out. Most patients with coronary heart disease do not have a classic lipid disorder or even elevated LDL cholesterol. Now, statin drugs can prevent about 35% of these events, but there's a significant amount of risk that remains. And advanced disorders, what we deal with, are actually more common than the elevated LDL cholesterol. But coronary heart disease is a family disease. It affects the entire family, and never assume that it's not going to happen to you because you're taking care of yourself diet-wise and exercise. If it's in your family, you are going to have the risk. Advanced tests can explain a significant portion of the contributors. So we have some new guidelines that came out a few months ago, and basically they still hold to the premise that lifestyle, healthy lifestyle, is extremely important and can reduce risk and prediabetes moving to diabetes at all ages. So patients with known heart disease should use statins to lower their LDL cholesterol by at least 50%. If they're very high risk atherosclerotic cardiovascular disease patients, want the LDL less than 70, treated with medicines. In severe primary hypercholesterolemia, like we saw with the genetic form, if the baseline LDL starts at 190 or higher, we want to get the target down to less than 100. And if the baseline is 220 or higher, we want to get it down less than 130. Now, that's the high-risk people. The new guidelines are very extensive, so they have ranges for people who aren't as sick as the ones we mentioned. You've seen the advertisements on TV with the injectable medicine, the PCSK9 inhibitors that can lower cholesterol 63% on top of statins. Wonderful drugs for the highest risk people. Wonderful drugs, okay? But the main theme with the guidelines is lower is better. Lower LDL cholesterol is better. Statin intolerance. Probably several of you out there have experienced statin intolerance. Muscle aches, joint pains, fatigue, whatnot. Can't take any of those statins, okay? We specialize in dealing with those patients, all right? One of the problems is people come with preconceived notions that the statin's going to be a problem and they're going to have trouble with it, and they just don't want it. They may have had a friend, a relative who had an experience, and they just don't want any part of that, or they read the internet. Internet, not an excellent source for a lot of information on this, okay? So what do we look for in people who are statin intolerant? Two big things right off the bat. Dehydration. If you're not drinking enough water every day, you're going to be prone to muscle aches and joint pains, especially if you're drinking caffeine, coffee, sodas, tea throughout the day, increased alcohol, regular alcohol, fluid pills for blood pressure. All those cause dehydration. Hydrate. The next is low vitamin D level. The range is long, it's 30 to 100, but I find that if we get patients' vitamin D level up to 50 or more, a lot of these aches and pains and night cramps are going to go away. People who exercise too much, too soon, without taking it easy, may have muscle and joint pains as well. Or if they're using muscles that they haven't used in a while, that can be a problem. Those with underactive thyroid, hypothyroidism, that in itself can cause muscle aches. But if it's not properly treated and statins are taken, it can lead to muscle aches. And then drug interactions with other medicines, that really should be up to the pharmacist and your clinician to make that determination that you're not going to have a problem. Just to mention a couple of newer lipid treatments, was a study that came out last year using a prescription fish oil, a very high-grade prescription fish oil. And these patients were adults. They had well-controlled LDL cholesterol, but they had cardiovascular risk factors, and their triglycerides were at least 135. So either diabetic or with heart disease and other risk factors. And prescription of pure EPA fish oil, 4,000 milligrams per day, reduced cardiovascular events, 20% cardiovascular death, 31% myocardial infarction, heart attack, and 28% stroke. That's pretty impressive, very impressive. And then in adults with established disease who are on diet and maximally tolerated statin therapy, but not at LDL goal of less than 70, that's when the PCSK9 inhibitors can come in and be used to reduce heart attack. This study showed 27% relative risk reduction in heart attack, and stroke was 21% in just a 2.2-year period. And certainly there are many other novel medications or in various stages of clinical trials that we'll have available to us. So from the standpoint of cholesterol, awareness saves lives. Learn all of your risk factors for cardiovascular disease. Family history, one of the most important, powerful risk factors that we know. Do your part to improve your lifestyles. Cardiac events can be prevented, truly. We want you to be a survivor and not become a statistic. Let's talk about metabolic health for a minute here. So this shows increased cardiovascular risk in the center, and around there are all the risk factors which can contribute to that. The dark blue are those we can't change. Genetics, what we're born with, age, race, sex, history of an event. We can't go back and undo that event. But the lighter blue are things we need to know about and we can control. Smoking, terrible. Please, if you smoke, you're just running down a rocky road. Physical inactivity and diet, the lipid disorders, high blood pressure. Not only type 2 diabetes, but metabolic syndrome, prediabetes, very important. Overweight. Metabolic syndrome, you need to know about this. It's the coming together of 5 criteria which defines that person as pre-diabetic or certainly at risk for heart disease, okay? So these are the criteria. Waist circumference in women over 35 inches, unless you're Asian, and then it's 32 inches. For men, they shouldn't have a waist over 40 inches. And I tell men all the time, I don't want to know your belt size. That's not your waist. I'm going to measure up here at your pelvic bones. I'm going to go closer to your belly button. That needs to be no more than 40 inches. And for Asians, it's about 35 inches. Blood pressure. If your blood pressure is 130 on the top number or 85 on the bottom number or higher, or if you're being treated for blood pressure, that's another criteria. Blood sugar of 100 or more. Fasting blood sugar 100 or more. Triglycerides 150 or more. And low HDL for women less than 50, for men less than 40. Any 3 of these, and you have metabolic syndrome, a pre-diabetic, pre-heart disease condition. If you have 4 or 5 of these criteria, we call you a diabetic in training, because it's probably a matter of when, not if. So things associated with the metabolic syndrome, certainly you can see the arrows on the right, atherosclerosis, endothelial dysfunction, that little yellow layer on the inside of the blood vessel wall that protects the cholesterol from coming in, it becomes weak. Insulin resistance on the other side. And look at the things that we typically see in metabolic syndrome patients. High blood pressure, obesity, too much insulin, actual diabetes, high triglycerides, the small, dense LDLs with the triglyceride in them, so they're much more numerous, low HDL cholesterol, and increased clotting problems. So insulin resistance is the inability of the body to drive glucose into the muscles, so the insulin level goes up, but it also makes the triglyceride go up. Another term for fat is adiposity. You may see that in some reading. Adiposopathy is a term for sick fat. Sick fat is that which is deep in our bellies, around our liver, in the liver, over in the intestines, around the heart and kidneys. It puts out a lot of inflammatory conditions and increases the risk of heart disease. So it affects the circulating levels of our lipids. the inflammatory products. Our HDL doesn't work as well. Again, obesity, metabolic syndrome, type 2 diabetes, high blood pressure, fatty liver, gout, gallstones, hypothyroidism. I see patients every day that have this whole clustering of things. So the hidden lipid and lipoprotein dangers in diabetics, okay? The LDL cholesterol on the lipid panel does not always match up to the number of LDL particles. The particles in diabetics are small. LDL particles are small. And the core is cholesterol depleted. It's got more triglyceride in it. So what does it mean? It takes more of those particles to carry that cholesterol. The triglycerides are higher. They promote inflammation and plaque. The HDL is lower. The HDL particles are smaller. They don't carry all those good protective proteins. So in many cases, it's no longer good. It can even be pro-atherogenic and cause atherosclerosis. And the risk of cardiovascular disease in prediabetes and diabetes precedes the sugar going up, okay? So all these other things, before the sugar even goes up, is putting you at greater risk for cardiovascular disease. Over 50% of newly diagnosed type 2 diabetics already have coronary artery disease. They just don't know it. And the risk of a heart attack in a diabetic is twice that of a non-diabetic. So here's some healthy tips for insulin resistance. Avoid sugary drinks, especially those sweetened with high fructose corn syrup, like we see a lot of our sodas. Terrible, toxic actually. Reduce saturated fats to less than 7% of total calories. Limit the starchy foods, bread, rice, potatoes, pasta. Healthy omega-3 fatty acids from salmon and tuna. But tuna fillets have much more than the tuna in the can. If you have high cholesterol, I would avoid coconut oil. As I heard Catherine say before, it's a saturated fat. It can actually increase the cholesterol in people who already have high cholesterol. Keto diet. We had a lot of questions at the table about keto diet. This is the thing. It does a great job in almost everybody of lowering the weight, lowering the blood sugar, lowering the blood pressure, but in a certain subset of people, your cholesterol is going to go way up. So what you need to do is, if you're going to get on keto, you need to get a lipid panel, and then once you're into it about 6 weeks, get another fasting lipid panel and see what's happening to your cholesterol. If it's going way up, you probably need to get off the keto. We all need to control portion sizes, and if we're overweight, just losing 7.5% of that body weight is going to make some significant metabolic changes in the body. And we look for exercise at a minimum of 150 minutes a week. That's going to kind of keep you there and give you some cardio. If you want to lose weight, you need to be up at 300 minutes per week. Here we go. All right, ladies, you are the heart and soul of your families, right? Help us and your clinicians to help you keep that heart beating, and we want to help you one heart at a time. Thank you very much.